Good morning everyone, this is Clinical Assignment 12 which will be presented by Guinevere, Melissa and Benny and I, Genevieve Tang. This is the question given. A 5-day-old baby was brought to pediatric emergency department with severe dehydration and hypotension. It had vomiting and poor oral intake in the first few days of life. During examination, it was found out to have ambiguous genitalia. Initial laboratory investigation was performed as we can refer to Assignment 11. Karyotyping review 46XX. Diagnosis was made after performing a special laboratory test. These are the questions that we will discuss in the video later. The key points of this assignment is dehydration, hypotension, vomiting, poor oral intake, found out to have ambiguous genitalia, and findings of karyotyping is 46XX. This indicates that this baby is a female. The diagnosis is congenital adrenal hyperplasia, which is an autosomal recessive disorder. This is mainly due to the deficiency of an enzyme in the synthesis of cortisol and aldosterone. The special diagnosis biochemistry laboratory test that we can do is to measure the enzyme 17-hydroxyprogesterone, which is also known as 17-OHP. We can do it by staining the blood sample on Goodyear card through heel stick technique. The expected result is elevation concentration of 17-OHP, which is more than 10,000 nanogram per deciliter. However, the baseline for 17-OHP in newborn babies are basically less than 630 nanogram per deciliter.
So now I'm going to talk about the pathophysiology of this case. In this case, there is an enzyme deficiency which is 21-hydroxylase due to a mutation of CYP21A2 gene. In a normal person, the function of this enzyme is to convert 17-hydroxyprogesterone to 11-deoxycortisol, which is a precursor for the synthesis of cortisol. So when there's a deficiency of 21-hydroxylase, it will lead to accumulation of substrate, which is 17-hydroxyprogesterone, and also decreased production of cortisol. In accumulation of the substrate 17-hydroxyprogesterone, it will then tend to use alternative pathway in order to synthesize your testosterone. The effect of synthesis of aldosterone will also be affected because aldosterone will use the enzyme of 21-hydroxylase to convert progesterone to deoxycorticosterone. It will also lead to an increase of ACTH, which is known as adrenocorticotropic hormone, and also increase of production of DHEA and also androstenedione. Therefore, without cortisol, there is a failure of negative feedback and excessive secretion of corticotropin releasing hormone from the hypothalamus, which will then lead to an increased secretion of ACTH from anterior pituitary. With this continuous of secretion of ACTH will causes the stimulation of the adrenal cortex, hence causes adrenal hyperplasia, which then we can conclude that this case is a congenital adrenal hyperplasia.
Now I'm going to talk about the consequences of the disorder in terms of clinical features. Since the baby is only 5 days old, this happens on an early onset, giving an indication this is an inherited metabolic disease, IMD. Congenital adrenal hyperplasia is one of the IMD. Severe dehydration and hypertension is due to defective production of aldosterone. When aldosterone is low or not produced, this results in sodium loss and water loss, causing dehydration and reduction in blood volume, and then causes hypertension. Abnormal heart rhythm is caused by hyperkalemia, abnormal menstrual periods, early appearance of armpit hair, excessive hair growth of facial hair. These are due to more androgens is produced. Male characteristics appear early or inappropriately, in this case in a female. Vomiting is due to low or no cortisol, results in decreased digestive enzymes in stomach. The consequences of the disorder in terms of biochemical are low serum aldosterone due to 21-hydroxylase deficiency, high serum renin, low or no aldosterone induced juxtaglomerular cells to release more renin, so more renin is found, low serum cortisol and low serum glucose will be observed. This might be due to 21-hydroxylase deficiency. Cortisol can increase hepatic gluconeogenesis, increase lipolysis and protein breakdown, which provide glucogenic sources. The baby is vomiting and having poor oral intake, so lipolysis, protein breakdown, and gluconeogenesis are expected to occur to supply glucose to the body. Since all this cannot happen, serum glucose will be low. High serum 17-alpha-hydroxy progesterone will be observed. Since progesterone cannot be converted into 11-deoxycorticosterone by 21-hydroxylase, progesterone will be converted into 17-alpha-hydroxy progesterone, so 17-alpha-hydroxy progesterone is high. High serum testosterone is as well observed. Since the body lack of 21-hydroxylase giving low or no cortisol, the adrenal cortex is directed by hypothalamus and pituitary gland to synthesize more cortisol. As cortisol and aldosterone synthesis pathway are blocked due to 21-hydroxylase deficiency, adrenal cortex synthesis more androgen, more testosterone is synthesized, so testosterone is high. The diagnosis is congenital adrenal hyperplasia as the patient is having the features of this disorder. Adrenal cortex synthesizes cortisol, aldosterone, and testosterone. This baby girl is presented with male characteristic due to high testosterone. Reduced aldosterone, cortisol, and high testosterone are observed due to deficiency of 21-hydroxylase.